Hi everyone, how are you doing? So today we'll be covering the remaining part of the reproductive, that is the reproductive pathology and the reproductive pharmacology. So you can watch the video along with your first aid and annotate as and when. Now while revising, watch the video on a 2x for a super rapid revision. If you want my PDF, then you can DM me on my Instagram channel @GramChronicles, the link to which is in the description. To access the previous videos, click on the link above or link in the description box. I've also included my personal notes as well for some topics which I thought that required more correlation. You can use your own notes and add in your info whenever you find it relevant or you come across some volatile topics. So let's start with reproductive path, and the first topic in reproductive path are sex chromosome disorders. Okay, so the sex chromosome disorders, they are usually due to aneuploidy, right? And the most common cause of aneuploidy is meiotic non-disjunction. Now let's review the disorder one by one. So the first disorder that we'll study is the Klinefelter syndrome. The Klinefelter syndrome is characterized by a male karyotype, that is the presence of 47XXY chromosome. Since there are two X chromosomes, so bar body, which is nothing but an inactivated X chromosome, will be present, right? Bar body is given by the formula number of X chromosomes minus 1. So here there are two X chromosomes, so there will be one bar body present. It is characterized by testicular atrophy, a tall stature. Then you can see the proportions are unicoid, right? So why this happens is that there is delayed epiphyseal closure that leads to increase in the length of the bones. The other features are gynecomesia and female pattern of hair distribution. Developmental delay may also be seen. Then the next feature is hypogonadism, which is the cause of infertility in such individuals. So why this happens is that there is dysgenesis of the seminiferous tubules, right? This leads to decrease in inhibin B, causing an increase in FSH. Also, the Leydig cells are abnormal, leading to a decreased testosterone that leads to an increase in LH and subsequently an increase in estrogen. So the hormone profile would be increase FSH, increase LH, that is hypergonadotropic hypogonadism, because the testosterone is decreased. The next disorder that we'll study is the Turner syndrome. So a Turner syndrome is characterized by a female karyotype, that is 45XO. Since there is only one chromosome, so no bar body is present. Usually the loss of X or Y chromosome is due to paternal gametes, that is the sperm is missing the sex hormones. Another important cause of Turner syndrome can be due to errors in mitosis. So this happens after the zygote is formed, and that leads to loss of sex chromosome in some of the cells, that is some cells will have 45XO while the other cells will have a 46XX or a 46XY karyotype, and this is called as a mosaic karyotype. Now, a mosaic karyotype is associated with increased risk of gonadoblastoma. So the management is an immediate gonadectomy. The Turner females are characterized by a short stature. This is associated with Shock's gene, right? Remember short for shocks. This type of short stature can be prevented by administering the growth hormone. The other features are gonadal dysgenesis, shield chest. It is associated with bicuspid aortic valve and coarctation of aorta. There will be a brachiofemoral delay, right? That is, the brachial pulse will appear, but there will be a delay in the femoral pulse, or there is loss of synchronicity. Then there are lymphatic disturbances like presence of a cystic hygroma or a webbed neck. Other associations are horseshoe kidney, high arched palate, a short fourth metacarpal, primary amenorrhea. There is menopause before menarche. Why this happens is that due to decreased estrogen, there will be increased LH and FSH. In these type of females, pregnancy is possible by the use of artificial reproductive methods like IVF and administration of estradiol 17 beta and progesterone. The next disorder is a double Y male. So here, like the Klinefelter was 47XXY, the double Y males are 47XYY. So they are phenotypically normal, and hence they usually go undiagnosed. These males are very tall, the fertility is also preserved, and they may be associated with severe acne, learning disabilities, and even autism spectrum disorder. Next are the ovotesticular disorders of sexual development. So here the karyotype can be either 46XX or 46XY, 46XX being more common. These were initially or earlier known as true hermaphrodites because they have the presence of ovotestes and the genitalia is ambiguous. Now when we talk about disorders of sexual development or DSD, here what happens is that there is a disagreement between the phenotype that is influenced by the hormones and is the external genitalia, and the genotypic sex, which is governed by the Y chromosomes and determines the gonads. For example, in case of 46XX DSD, the gonads are ovaries, but the external genitalia is virilized, that is, there is clitoromegaly, leading to the presence of ambiguous genitalia. Similarly, in case of a 46XY DSD, the gonads are testes, but the genitalia are ambiguous, that is, there is a micropenis. So these disorders where there is a disagreement between the phenotype and the genotype, they are called as DSD or intersex. Earlier, these individuals were called as pseudohermaphrodites. The most common cause of a female pseudohermaphrodite or a 46XX DSD is congenital adrenal hyperplasia, which is increased exposure of androgens during the gestation, right? If CAH occurs after gestation or in a neonate, then the genitalia would be normal. The most common cause of CAH is 21 hydroxylase deficiency followed by 17 hydroxylase deficiency. 21 OH hydroxylase deficiency leads to a female, while 17 OH may lead to a male hermaphrodite, pseudo-hermaphrodite. The most common cause of a male pseudo-hermaphrodite is androgen insensitivity syndrome. Now, talking about the workup of DSD. So, if the question asks what will be the next step in an infant or a neonate presenting with ambiguous genitalia. So, the next step is a physical examination, very important. Right. On physical examination, you look for the secondary sexual characteristics like breast and pubic and axillary hair. Right. If the question asks what is the best investigation, then the answer changes to karyotype. So, it is very important to read the question whether they are asking the next or the best investigation. Now, after physical examination, an ultrasound is performed to see whether the uterus is present or absent. If the uterus is present, then hormonal study is carried out and LH and FSH are measured. If they are increased, it means it is hypergonadotrophic hypogonadism. If it is decreased, then it is a case of hypogonadotrophic hypogonadism. The examples of hypergonadotrophic hypogonadisms are Turner, that is 45XO, mosaicism, that is 45XO and 46XX or XY, and pure gonadal dysgenesis. Hypogonadotrophic hypogonadism का example is Kallmann syndrome, where there is involvement of KAL1 gene that leads to defective migration of the neuronal cells, causing defective development of olfactory bulb, leading to decrease in GnRH and subsequently decrease in LH, FSH and testosterone. It is also associated with anosmia due to defective olfactory bulb development. Talking about the condition where uterus is not present, then we see whether breasts are present or absent in such individuals. Now, if the breast is absent, then it means that it is a male with decreased secretion of testosterone, while if a breast is present, then the next step will be to perform the karyotype. For a female karyotype, the diagnosis is MRKH syndrome or Mullerian agenesis, and for a male karyotype, the diagnosis is androgen insensitivity syndrome. Right? We already studied it is a 46XY DSD. It is characterized by a scant hair, rudimentary vagina, uterus and fallopian tube being absent, while in MRKH rudimentary vagina, fallopian tube or a blind ending vagina is seen. Right. Why this happens is because there is anti-Mullerian hormone in such individuals as the karyotype is XY. Then normal testes are present within the labia majora and the management is gonadectomy after puberty. So, this is the approach for DSD. First is physical examination and ultrasound, then is hormonal study if uterus is present, and karyotype in case of absent uterus in the presence of development of breast. The diagnosis for absent uterus with normal breast development would either be MRKH syndrome if the karyotype is female or androgen insensitivity syndrome if the karyotype is male. Then in cases where uterus is present, the causes can be either hypergonadotrophic hypogonadism or hypogonadotrophic hypogonadism. This is a very important approach. Again, two important questions. Next step, physical examination, and best step is a karyotype. Next cause of DSD is placental aromatase deficiency. It is a 46XX DSD. So here what happens is that the androgens are unable to be converted into estrogen due to the deficiency of aromatase. So this leads to masculinization of the female, right? And the female will hence present with ambiguous genitalia. In such cases, the testosterone is increased because they are not converted to estrogen. Also, there will be increased androstenedione. In cases of a pregnant female, there will be virilization because the fetal androgens can cross the placenta. The next condition is 5-alpha reductive deficiency. It is an autosomal recessive disorder and it is a 46XY DSD. Here what happens is that due to the deficiency of 5-alpha reductase, the testosterone is not being converted into dihydrotestosterone, leading to external genitalia, but this is only until puberty. After puberty, due to increased testosterone, the external genitalia will develop into a male genitalia. It is also characterized by a normal testosterone and estrogen levels, while the LH levels are usually normal, but they may also be increased. So this completes with the DSD. Let's move ahead to the next topic, which is the complications in the pregnancy. So we'll be reading about the first set of complication that includes the various causes of antepartum hemorrhage, especially in the third trimester. The first complication that we are studying is abruptio placenta. So abruptio placenta is nothing. It is the premature separation of the placenta in the third trimester. It is characterized by abrupt, right? It is in the name only, abruptio, painless bleed, which can either be apparent, that is a revealed abruption, or it can be concealed. For a concealed abruption, on UST, a retroplacental clot can be seen. So here in the diagram you can see this is a concealed abruption. Here behind the placenta a clot is seen. So how on UST this appears is that it will be echogenic because it is blood. While in case of apparent abruption, there will be bleeding through the vagina. The risk factors for abruption are trauma, smoking, hypertension or preeclampsia, and use of cocaine. That is all the causes that are causing vasoconstriction and leading to uteroplacental insufficiency. Due to abruption, there is stimulation of tissue factor and hence it leads to DIC, shock and fetal distress. Abruption is a life-threatening condition for both mother and the fetus, right? And remember, abruption is associated with DIC due to activation of tissue factor. The next complication are the placenta accreta spectrum disorder. So in placenta accreta, what happens is that there is a defect in the decidual layer leading to abnormal attachment and therefore abnormal separation of the placenta. Based upon the depth of penetration, it is divided into placenta accreta, increta and percreta. In placenta accreta, the placenta attaches to the myometrium, but it does not penetrate it. In increta, the placenta penetrates the myometrium, while in percreta, it extends beyond the myometrium, that is perforates through the myometrium into the uterine serosa. In placenta percreta, the placenta can even attach to the rectum or the bladder, leading to hematuria. So here in the diagram we can see a normal placenta separated from the myometrium by the presence of stratum basalis. On ultrasound, this will appears as a hypoechoic layer between the echogenic placenta and the myometrium. In case of placenta accreta spectrum disorders, there is loss of this hypoechoic layer, and therefore it is easily diagnosed on ultrasound. The complications of placenta accreta can be PPH due to adherent placenta, which is very difficult to separate, and this may even lead to Sheehan syndrome. The next complication is placenta previa. Placenta previa is a low-lying placenta which lies within 2 cm of the internal os. Earlier there were 4 grades of placenta previa, in which grade 2B used to be a posterior placenta which was very dangerous. 3 was an incomplete placenta and grade 4 was a complete placenta previa. Now we use only incomplete and complete placenta previa. So an incomplete or a partial placenta previa is placenta covering the internal os which is within 2 cm, but it does not cover it completely, while complete placenta previa would cover the internal os completely, as it can be easily seen in the diagram. It is diagnosed in the 3rd trimester and it is characterized by painless bleed in contrast to abruption where there was painful bleeding. The next complication is vasa previa. It is usually associated with velamentous cord insertion, that is, the cord inserts into the chorioembryonic membrane. So the fetal vessels run over the internal os. It is characterized by a triad of membrane rupture, painless bleeding per vaginum, and fetal bradycardia where heart rate is less than 110 beats per minute. So these were all the antepartum complications. One more thing, for vasa previa, the investigation is APT test, which differentiates between the maternal and the fetal blood. We did this last time, and it is managed by performing an emergency C-section. Right, in placenta previa, if the female is stable, then a McAfee protocol is followed. The next complication we'll be studying is postpartum hemorrhage. So the causes of postpartum hemorrhage are done by the 4T, that is tone of the uterus or uterine atony, which is the most common cause, trauma, thrombin or coagulopathy, and tissue, that is retained products of conception. So what is important in PPH is its management. For prevention of PPH, AMTSL or active management of 3rd stage of labor is done. The components of AMTSL are intermittent uterine tone assessment, controlled cord traction, delayed cord clamping, and administering oxytocin and other uterotonics. This is very important, right? Now management of PPH, that is if PPH occurs, so if it is due to the retained placental tissues, then the management would be performing dilatation and curettage. In cases of traumatic PPH, you look at the cause, whether it is perineal, cervical due to hematoma or uterine rupture. In cases of perineal trauma, a pudendal block is given, right? Then the repair is done by first repairing the rectal mucosa, followed by the repair of internal anal sphincter, then external anal sphincter, and finally the vagina. The cervical trauma, the block given is paracervical block and the repair is performed. In case of hematoma, ice pack and analgesics are used. Surgery is done in unstable patients. And in case of rupture of uterus, immediate lap is done. If the patient does not respond or there is no response, then hysterectomy is performed. In case of atonic BPH, now this is very important. This is asked in all the exams every time. So first you give uterotonics like oxytocin. The name of oxytocin is carbetocin and the dose is 100 microgram. This was asked in 21 INI-CET. Then another uterotonic is PGF2 alpha, which is a carboprost, and the dose of carboprost was again asked in 2019. Therefore, you can see that uterotonics are very important and you should know all the drugs. So carboprost, the dose is 25 microgram. What was asked was the maximum dose of carboprost. So 8 doses can be given and the maximum 2 milligram carboprost can be given. The dose of oxytocin is 10 international unit and dose of misoprostol, which is a PGE1 analog, is 800 micrograms. Right? If this does not control the bleeding, then mechanical compression can be given. Still no relief, then uterine artery embolization or compressive sutures can be performed, which are the Belian sutures. Still no relief, then a devascularization surgery is performed. This was asked in NEET 2021 that what do you ligate? So we first perform the uterine artery ligation. If it fails, then anterior division of internal iliac artery is ligated. If the patient is stable, then only we perform this. In case of unstable patients, the devascularization surgery performed is a subtotal hysterectomy. The next set of complications are early trimester bleed. So the workup in such cases include a urine pregnancy test and a beta HCG. For UPT positive cases and beta HCG more than critical titer, which is again very important, the critical titer of beta HCG on transvaginal ultrasound is more than 2000, while in transabdominal ultrasound is more than 6000. What is critical titer? That it is the value of beta HCG at which we can see the gestational sac on imaging. So if the beta HCG is more than its critical titer in a UPT positive patient, but a gestational sac is not seen in the uterus, it can mean that there are three things that have happened: abortion, ectopic pregnancy, or the pregnancy is early. In case of early pregnancy, what we do is that we will ask the patient to come after 1 week and we will again check for the gestational sac. Also, the second thing that we do is we follow up with beta HCG. So if the beta HCG decreases after 48 hours, it means that it is an abortion. If it plateaus, it indicates an ectopic pregnancy, while if it doubles after 48 hours, it means that it is an early pregnancy, which is again confirmed after 1 week by repeating the ultrasound scan. Now all of these have been covered in detail in my PDF, that is OBS Rapid Revision, right? Here we will quickly go through the ectopic pregnancy, which is a cause of early trimester bleed, and molar pregnancy, which is another cause of early trimester bleed. So let us start discussing the ectopic pregnancy. Right. The most common site for ectopic pregnancy is the ampulla of the fallopian tube. The other sites include its isthmus, where there is a highest risk of tubal rupture, and the pregnancy first ends in the isthmus, while the pregnancy that is maintained up to 12 weeks is in the interstitium. Why? Because it is close to the uterus and hence it is maintained for the longest time in the interstitium. The other sites can be abdomen or the peritoneum, ovary and the cervix. So for abdominal pregnancy, the criteria that we use is a Studiford criteria. For ovarian ectopic, the criteria used is Spielberg, while for cervical ectopic, the criteria used are the Rubin and Palman criteria. Now, the cervical ectopic appears like an abortion, because abortion will also come down through the root of the cervix. So how will we differentiate between a cervical and an abortion? In abortion, when we try to move the conceptus from side by side, it will move, while if it is implanted or it is an ectopic, then it will not move on probing. Right? So for abdomen, Studiford criteria, ovary Spielberg, and cervix, Parman or Rubin criteria, showing a figure of 8 appearance. The risk factors for ectopic pregnancy are scarring of the fallopian tube, which can be due to either an infection, that is the PID causing salpingitis, or surgery. Other risk factors are previous ectopic, IUD, and IVF. Why? Because in all these procedures there is manipulation of the fallopian tube, leading to scarring and hence increasing the chances of ectopic pregnancy. Now, ectopic pregnancy is characterized by pain which is much more than bleed. While if you compare it with abortion, in abortion there will be bleed which is out of proportion to the pain that it causes. So the pain or the bleed would be in the first trimester, that is it is an early trimester bleed, and it mimics appendicitis. The patient will complain of the patient will present with history of amenorrhea with lower than normal beta HCG levels. For investigation, we will do an ultrasound, and on ultrasound what will we see is a ring of fire appearance, or a bagel sign on Doppler. Right. This appearance is also seen with thecal uterine cyst. So how will you differentiate it is that the wall will be echogenic for an ectopic pregnancy, and on follow-up you may even see embryo and yolk sac in the adnexa. For management of ectopic, we need to see whether the ectopic is ruptured or unruptured. In case of a ruptured ectopic or the patient is unstable, the treatment of choice is laparotomy and a salpingectomy. While for unruptured ectopic and a stable patient, we see whether the beta HCG is less than 1000, cardiac activity absent, a sac less than 4 cm, or no contraindications to methotrexate are present, like pulmonary disease, CKD, alcoholic liver disease, a breastfeeding female, and hematological disorders. In such cases, medical management can be given, where monotherapy with methotrexate is done, and we follow up with beta HCG, and a decline of beta HCG to more than 15% between day 4 to day 7 means that the therapy is adequate. So injection methotrexate can be given for 3 times. While if all these conditions are not met, then we perform, or the procedure of choice, treatment of choice would be a surgery. Here laparoscopic salpingectomy is done for a patient with a complete family, and salpingostomy is done if the family is incomplete. The second cause of early trimester bleed or first trimester bleed is a molar pregnancy or a hydatidform mole. So here what happens is that there is cystic swelling of chorionic villi, and there is proliferation of chorionic epithelium, which is the trophoblast. It is associated with sequelae of increased beta HCG, right, like early preeclampsia, that is preeclampsia before 20 weeks, presence of thecal uterine cyst, hyperemesis, and hyperthyroidism. Right, these are all due to increased beta HCG. Now talking about molar pregnancy, it is of 2 types, complete mole and partial mole. So in complete mole, the karyotype is 46XX, which is more common than a 46XY karyotype, while for a partial mole the karyotype is 69XXX, a 69XXY or a 69XYY. It is the complete mole is composed of enucleated egg and a single sperm. So there is basically duplication of the paternal chromosome, while in partial mole there will be 2 sperm and 1 egg, hence the triploid chromosome. If you talk about histology, there will be hydrophic villi with diffuse trophoblastic proliferation in the complete mole, while in partial mole there will be some villi which are hydrophic and the trophoblastic invasion will be minimal. Fetal parts are not seen in complete mole. So this is an example of complete mole where you cannot see any fetal part, while presence of fetal part means that it is an incomplete mole. While performing staining for P57 protein, it will be absent in the complete mole because it is paternally imprinted, and here we studied that there was duplication of the paternal chromosome as a single sperm was involved, while P57 staining will be positive as it is maternally expressed in a partial mole. Yeah, you can remember that P57 is positive for partial mole, PP. Then uterine size will be increased in both. Beta HCG will again be increased in both, but the rise would be more in complete as compared to the partial mole. If you talk about the imaging, so the complete mole shows a honeycomb uterus or a cluster of grape appearance on growth, as you can see here, while on imaging the characteristic appearance is the stostorm appearance. While in incomplete mole you can see fetal parts as well, which we discussed already. Now the risk of invasive mole is 15 to 20% in complete mole, while it is less than 5% in a partial mole, while the risk of choriocarcinoma is around 2% in complete mole, while it is very rare in partial mole. Talking about the treatment of choice, so the treatment of choice for molar pregnancy is suction and evacuation using a Carmen cannula. Now, very important is that oxytocin is not given for induction of labor, but it can be given after the induction. For follow-up, we use beta HCG, and a weekly monitoring is done till 3 readings are normal. If between 7 to 9 weeks the 3 readings are normal, it indicates a complete resolution, and if there is complete resolution, then we can perform the follow-up every month for 6 months. During this time period, the patient is advised to not undergo conception, as conception increases the risk of molar pregnancy. Then for contraception, the contraception of choice would be a low dose OCP or a barrier method. This question was asked this year in NEET PG, that IUD is contraindicated in molar pregnancy because it increases the risk of uterine rupture. Right. For partial resolution, we see whether the HCG is more than 10% in 3 weeks, or there is a plateau of beta HCG in 4 measurements in 3 weeks, that is on day 1, day 7, day 14 and day 21. If there is a plateau, it means it is an invasive mole, while if the increase is more than 10%, it indicates a choriocarcinoma. Now, invasive mole is associated with molar pregnancy, and here on histopath you can see chorionic villi invasion. While for choriocarcinomas, the villi are absent. It is basically a malignancy of the trophoblastic tissue. So these are all trophoblastic tissue, and here we can see that there are no villi. No villi are seen on histopath. What we can see are dimorphic trophoblast. That is, there is presence of cytotrophoblast and syncytiotrophoblast. Comparing it to placental site trophoblastic tumor, that is PSTT. So here there will be monomorphic trophoblast only, and it is positive for HPL. Choriocarcinoma is associated with increased thecal lutein cyst bilaterally, and it is characterized by persistent bleeding per vagina, shock or free fluid in the peritoneum due to uterine perforation, subinvolution, and METs, the most common site being lungs more than vagina. Vaginal METs would present as purpuric nodule or as suburethral nodule, and for vaginal METs the biopsy is contraindicated as they are hemorrhagic. Now, very important to know is the staging of the GTN, where stage 1 is the tumor limited to the uterus, 2 is reaching the pelvis, that is the vagina and the adnexa. This is very important, which is always asked, that involvement of lungs, that is lung METs or the cannonball METs, are a good prognosis, and they are included in stage 3, while METs to any other site are included as stage 4. So, cannonball METs we can see in choriocarcinoma on ultrasound as large metastasis in the lungs. Another important, for prognosis, the WHO prognostic scoring is used, and based upon it the treatment is given for the gestational, for the GTNs. So, this was asked in 2021 AIMS, that what would be the treatment of a patient, and a whole clinical scenario was given. So, you need to calculate the score, and based upon the scoring, if the score comes out more than 7, the treatment is a multi-drug chemotherapy of the regimen IMACO, that stands for etoposide, methotrexate, actinomycin D, and cyclophosphamide, and oncowin, that is vincristine. While if the score comes out to be less than 6, then you can give methotrexate with folinic acid, and you can repeat it every 2 weeks. Right. So, you don't need to know the entire score, but you can look at the high risk features. So, what are the high risk features? Age more than 40, a term pregnancy, then interval since the last pregnancy more than 12 months, a very high value of beta HCG, that is more than 10 to the power 5, right, liver and brain METs, then increased number of METs, that is more than 8 METs, and previous failed chemotherapy to more than 2 drugs. So, these are all high risk features. If you know them, you can easily see that if these all things are coming, then the treatment would be a multi-drug chemotherapy of IMACO regimen, right? Or you can learn this also. It will only help you to solve questions. The next set of complications we'll be doing are the medical disorders in the pregnancy, and the first complication is hypertension in pregnancy. So, hypertension is defined as a blood pressure more than 140 by 30 2 times, but the measurement should be at least 4 hours apart, right? So, hypertension in pregnancy is further divided into 2 types. First is pregnancy induced hypertension. So, it is defined as increase in BP after 20 weeks of gestation, while any rise of BP in the first trimester or within 20 weeks is known as chronic hypertension. Now, what happens is that in a patient with chronic hypertension, if there is uncontrolled BP superimposed on it, it is called as superimposed hypertension it is known as chronic hypertension with superimposed preeclampsia. In such cases, the drug of choice is alpha methyl dopa, that is either for chronic hypertension or chronic hypertension with superimposed preeclampsia, the drug of choice would be alpha methyl dopa. Now, for pregnancy induced hypertension, it occurs due to incomplete trophoblastic invasion, and it resolves within 12 weeks postpartum, right? It is associated with increased anti-angiogenic factors like thromboxane A2, endoglin and SFLT1, while a decrease in angiogenic factors like VEGF and vasodilators like nitrous oxide and prostaglandin I2 or prostacyclin. So what happens is that there is effective vasoconstriction, and therefore the investigation that is useful is a Doppler. Now, pregnancy-induced hypertension is associated with a large placenta, that is placentomegaly, which can be seen in diabetes, twin pregnancy, a molar pregnancy and an Rh negative pregnancy. In a molar pregnancy, the preeclampsia may be early onset preeclampsia, that is, it may have an onset before 20 weeks. Now, if there is merely increase in BP more than 140/90 after 20 weeks period of gestation without pre-existing hypertension or proteinuria is absent or end organ damage is absent, then it is known as gestational hypertension. While if the BP is elevated or there is new onset hypertension after 20 weeks of gestation associated with proteinuria, that is more than 300 mg per day, or a dipstick showing more than 2+ proteinuria with or without end organ damage, it is called as preeclampsia. Now, preeclampsia is further divided into mild preeclampsia and severe preeclampsia. Mild preeclampsia is defined as a blood pressure of more than 140/90 with proteinuria, and for managing mild preeclampsia, the drugs or the antihypertensive drugs are started only when the BP rises to more than 150/100 on 2 occasions. If the BP is less than 150/100, then first we advise the patient lifestyle modifications. When the BP rises to more than 150/100, antihypertensive medications are started like labetalol, hydralazine, nifedipine and alpha methyl dopa, the drug of choice being labetalol, and the pregnancy is terminated at 37 weeks. For severe hypertension, the BP is more than 160/110 with signs of end organ damage. For managing severe preeclampsia, the drug of choice is labetalol, that is, IV drugs are given, right? But still the safest drug remains methyl dopa. If the hypertension is refractory, then sodium nitroprusside can be given, and also in such cases prophylactic magnesium sulfate can be started, and the therapeutic range of magnesium sulfate is 4 to 7 milliequivalent per liter. If it is more than the therapeutic range, it leads to magnesium sulfate toxicity, which is identified by decreased or absent patellar reflex, right, and decreased urine output, increased respiratory rate, etc. The antidote for magnesium sulfate is calcium gluconate. These are very important points that everyone must be knowing, but I am just brushing upon it very quickly. Also, if preeclampsia is severe, then the termination of pregnancy is done at 34 weeks itself. Now, preeclampsia can lead to impending eclampsia, which is identified by epigastric pain with or without nausea and vomiting, headache and visual disturbances. In such cases, vaginal delivery is done with prophylactic forceps and vacuum to decrease the second stage of labor. Right. In the third stage of labor, methyl ergometrin is contraindicated. C-section is done in cases when the Bishop score is poor or there is absent end diastolic flow or reversal of end diastolic flow. I will be talking about it in a while. And in such cases, that is either absent or reversal of end diastolic flow, general anesthesia is given. Otherwise, C-section can be done under epidural anesthesia. Now, eclampsia is nothing but preeclampsia with seizures. Here, there may be death due to stroke or intracranial hemorrhage, There may also be presence of ARDS. For treatment, first we do the ABCDE, that is the airway, breathing, circulation, right? The emergency management, and we do immediate termination of pregnancy. The mode followed is vaginal delivery is preferred more than C-section, and the drug of choice for eclampsia is magnesium sulfate. This was a question asked in this year INI-CET, right? And even the factors responsible for eclampsia and preeclampsia were asked, where thromboxane A2 and prostacyclin was given in one of the options, right? So thromboxane increases and prostacyclin decreases. That was the correct answer, right? So the drug of choice is magnesium sulfate, and we already read that the therapeutic dose is 4 to 7 milliequivalents. It is given by Pritchard's regime, that is the loading dose is IV 4 gram 20%, followed by IM 10 gram 10%, which is given 5 gram per buttock, while the maintenance dose is 5 gram 50% in alternate buttock. Now, it is given every 4 hourly till 24 hours after the last seizure. Now, for monitoring, you measure the patellar reflex, urine output, it should be more than 100 ml per liter, respiratory rate, and SpO2. Right? In case of toxicity, the first to be lost is the patellar reflex, which is lost at concentration of more than 10 milliequivalents. The next is respiratory depression caused at a dose of more than 15 milliequivalent, and finally, if the concentration rises more than 20 milliequivalent, it leads to cardiac arrest. Right? Also, renal disease is not a condition for adjusting the loading dose. Only the maintenance dose needs to be adjusted in case of renal disease. This was also a question that was asked, that how will you administer magnesium sulfate, right? So a vial of magnesium sulfate is 2 ml. It contains 50% of magnesium sulfate, that is 1 milligram of magnesium sulfate, right? So 4 vials will contain 4 gram magnesium sulfate in 8 ml, right? Now we have to make the concentration to 20%. So what we do, we dilute it by adding 12 ml NS. Therefore, in a 20 ml syringe, right, we will take 12 ml of NS and 8 ml of magnesium sulfate. 8 ml means 4 vials. Then 10 vials are used for the IM dose. So total 14 vials are used for the loading dose, right? There is another regime, which is the Zuspan or the Cibal, where loading dose is again 4 gram IV 20%, but the maintenance dose is 1 gram per hour. 5 milligram in 100 ml MS is given at the rate of 100 ml per hour. This is not that important, but Pritchard's regimen is very, very important, and this should be learned by heart. Now, what are the Doppler findings in preeclampsia? So the first finding would be the presence of a diastolic notch in the uterine artery for more than 24 weeks, right? So this is normal uterine artery Doppler. It should be something like this, while notching in the uterine artery is this. This is diastolic notch, right? So this, if it persists after 24 weeks, it is an indication that preeclampsia might be developing. Second, uterine umbilical artery is used for the prognosis. So what happens normally in umbilical artery, there is decrease in peripheral vascular resistance, that is the SD ratio increases. So this is S and this is D, systolic and diastole. So the ratio usually decreases as the term increases or as the gestation increases. But in PIH, what happens is that due to increase in peripheral vascular resistance, there would be an increase in S by D ratio. So what happens is that first there is absence of end diastolic flow, right? It touches the baseline, and when it goes beyond the baseline, it means there is reversal of end diastolic flow. So in end diastolic flow, the termination of pregnancy is done at 34 weeks, and therefore we need to administer corticosteroids, while If there is reversal of end diastolic flow, the pregnancy should be terminated at 32 weeks, and for pregnancies less than 32 weeks, both corticosteroids and prophylactic magnesium sulfate must be administered along with indomethacin, which is a tocolytic. Right? So, in end diastolic flow, the termination is done at 34 weeks and prophylactic corticosteroids are given, while for reversal, the pregnancy is terminated at 32 weeks itself and prophylactic corticosteroids and magnesium sulfate plus minus indomethacin or a tocolytic is given. Right? For other medical disorders like diabetes, heart disorders, I have covered them in detail in my video, that is rapid revision OBS, right? And in that, maternal adaptations, the link to which is given here, and it is also in the description. You can check it out. Now the next condition that is caused or that can be a sequelae of preeclampsia is a HELP syndrome, which is more commonly seen in the multigravida female. So HELP stand for hemolysis, then elevated platelet count, elevated liver enzymes and low platelet count, right? For hemolysis, there should be satisfaction of more than 2 of the following factors. First, there should be an increase in LDH more than 2 times the normal value with a decrease in haptoglobulin. Then anemia, increase in bilirubin more than 1.2 milligram per deciliter, and the peripheral blood smear showing Burr cells or schistocytes. Right. For management, immediate termination of pregnancy is done if the gestational age is more than 34 weeks, and prophylaxis with magnesium sulfate and antihypertensive drugs is done. For period of gestation less than 34 weeks, corticosteroids are administered, and after 48 hours, induction of labor can be done. HELP syndrome was asked this year, right? Yeah. So the next reproductive pathology is Gynae Cancers. Again, I have made a detailed video titled Gynae Cancers in less than 1 hour, the link for which is here and it is also given in the description. Here we will limit our discussion to first aid only. So the most common cancer in US is endometrial cancer, but in India and worldwide the most common gynecological cancer is the cervical cancer due to decreased HPV vaccination. Now for prognosis, the best prognosis is of cervical cancer, followed by endometrial cancer, followed by ovarian cancer. Right, you can remember it by the mnemonic CEO, and this is also the age criteria. Cervical cancer is usually seen in less than 45 years of age, endometrial in about 55 years of age, and ovarian cancer is seen in more than 65 years of age, and also this is worse prognosis. Now the first topic that we will be studying is the vulva. So let us first start with the non-neoplastic conditions of the vulva. The first topic is Bartholin cyst. Bartholin cyst is due to the blockage of Bartholin gland duct, right, and it is seen in the posterior introitus because that is where the Bartholin duct opens, right. Bartholin gland is homologous to the Cooper's gland, and if you see a cyst in the anterior introitus, it is due to periurethral gland cyst, which is also known as the gland of Skene, right. Remember, gland of Skene is homologous to the prostate gland and Bartholin is homologous to the Cowper's gland. For management of Bartholin gland cyst, the surgery is marsupialization, right, where the mucous membrane is everted to prevent its recurrence. Now, if there is infection in the Bartholin cyst, a Bartholin abscess may develop, And for the management of Bartholin abscess, the treatment is incision and drainage. The most common organism causing Bartholin abscess is E. coli. The next condition is lichen sclerosis. So, in lichen sclerosis, what happens is that there is thinning of the epidermis with fibrosis or sclerosis of the dermis, right? So, it gives the appearance of a porcelain white plaque, a red or a violet border. This is also known as the parchment paper appearance, right? Because it would be porcelain white with a reddish border, right? So this is like a parchment paper appearance. Now, Bartholin cyst is usually seen in women of reproductive age, while lichen sclerosis is commonly seen in postmenopausal women, and it is associated with increased risk of squamous cell cancer. On biopsy, again we'll see a thin epidermis with a sclerosed dermis, and the most common clinical feature in lichen sclerosis is pruritus. Next, we'll be studying lichen simplex chronicus. So, it is not associated with increased risk of squamous cell cancer, unlike lichen sclerosis. It is nothing but hyperplasia of the squamous epithelium. So, the patient presents with a leathery and a thick vulvar skin with enhanced skin markings. Why? Because there is chronic rubbing and scratching, right? So, this is lichen sclerosis and this is lichen simplex chronicus. The neoplastic condition, if we talk about, they include vulvar cancer and Paget's disease, which is nothing but extramammary Paget's disease. So, vulvar cancer is squamous cell cancer and it presents with leukoplakia, right? The preceding lesion is vulval intraepithelial neoplasia, which is of two types, usual VIN and differentiated VIN. In usual VIN, you will see basaloid cells, and the treatment is immunomodulators as it is associated with HPV infection. It is seen in younger patients. Now, differentiated VIN, it is seen in non-HPV cases, right? So, it is associated with lichen sclerosis and it is seen in older patients, that is more than 70 years of age. Now, vulvar cancer is a rare pathology. The investigation used to diagnose is a punch biopsy. HPV related cancers are due to HPV 16 and HPV 18, which are the high risk HPV. This was asked this year in NEET. The most important prognostic factor is stromal invasion or lymph node mets, and the sentinel lymph node in vulvar cancer is superficial inguinal lymph node. The next topic is extramammary Paget's. It is intraepithelial adenocarcinoma, right? That is it is carcinoma in situ with low risk of underlying carcinoma. It usually presents with pruritus, erythema, crusting and ulcers. On biopsy, there are pale ovuloid cells and the IHC markers is cytokeratin 7. This is very important, right? You should know everything about CK7 positive tumors, CK20 positive tumors, CK7 and CK20 positive and both negative. There is a list for all these, right? For treatment, wide local excision is done. So this completes the vulval pathology. Next, we'll be studying about the vaginal tumors. So the vaginal tumor most common is a squamous cell cancer, right? Primaries are rare. It is usually a secondary due to cervical cancer. Second is a clear cell adenocarcinoma, which is associated with DES exposure, and it is caused due to vaginal adenosis, right? What is adenosis? It means that the upper two-third vagina has persistence of glandular columnar epithelium. Next is sarcoma botrytis. It is a variant of embryonal rhabdo. Right, it is seen in females less than 4 years of age, and it is associated with spindle shaped cells like in rhabdomyosarcoma. It is desmin positive and it presents with grape like clusters. Now we finally move on to cervical tumor or cervical pathologies, and cervical cancer is very important, right? Cervical pathologies are always asked in exam, so let us just see it in a bit detail. So first we'll talk about cervical dysplasias and carcinoma in situ. What happens is that in dysplasia there is disordered epithelial growth, right? It begins at the basal layer of the squamocolumnar junction, which is nothing but the transitional zone, right, that we read between the endocervix and the ectocervix. Then from the transitional zone it moves outwards. Now dysplasia is classified into SIN 1, SIN 2, SIN 3 and carcinoma in situ, right? According to Bethesda classification, SIN 1 is LCIL, while SIN 2 or SIN 2 onwards is LCIL. This is Bethesda. Then SIN 1 is mild dysplasia, SIN 2 is moderate dysplasia and SIN 3 is severe dysplasia. What it means is that there is involvement of basal 1/3 of the epithelium. Here in SIN 2 it is around 2/3, in SIN 3 it is more than 2/3, while carcinoma in situ is full thickness dysplasia. And this was asked in last year NEET exam, that full thickness is involved. So what will the histopathology be called, or what will the pathology be called? So it is nothing but dysplasia, right? Also very important to note that in carcinoma in situ the basement membrane is not invaded. If the basement membrane is invaded, then it becomes an invasive carcinoma, right? Next very important point to remember is that it is associated with HPV 16 and 18, which is the high risk variety, and they both express or have proteins E6 and E7. What they do is that E6 is responsible for inhibiting the tumor suppressor gene P53 and E7 inhibits RB gene. How you can remember is that 6 and 7, 6 comes before 7, similarly P comes before R. So E6 will inhibit P53 and E7 will inhibit the RB genes. On histopath you will find coilocytes, These are cells with a wrinkled raisin-like nucleus, and there is a perinuclear halo. So this is associated with HPV infection. If it is untreated, it may lead to invasive cancer. Right? Now the risk factors include multiple sexual partners, HPV infection, smoking, early coitus, DES exposure, and immunocompromised states like HIV and a transplant patients. If you talk about the clinical feature, the patient is usually asymptomatic and are incidentally diagnosed on PAPs, while the most common symptom associated with it is postcoital bleed. Here let us look at PAPs. So PAPs is an important topic. It is used for screening cervical cancer, and the screening is started at 21 years of age. For patient between 21 to 29 years, the screening should be done every 3 yearly with PAPs. For people between 30 to 65 years, co-test is done, that is simultaneous testing of PAPs and HPV testing every 5 years. For people more than 65 years, only if there is history of SIN2 or 3 present, then additional 20 years of testing can also be done. Now, while reporting the PAPs, the report can either be a cell of unsignified significance, LCIL, ASCH, HCIL, and atypical glandular cells, right, of unsignified origin or not otherwise specified. Now, when you see AGC in the report, the next step is colposcopy plus endocervical curettage. For any condition with H like HCIL or ASCH, again the next step will be colposcopy. Now let us see about ascus, right, which is a cell of unspecified significance. Here we will see the age of the patient. If the person is between 21 to 24 years of age, then we repeat the PAPs annually. While for a person more than 25 years of age, the reflex test is done. Reflex test is nothing but PAPs followed by HPV, right? So if you do PAPs and HPV simultaneously, it is called as a co-test, while PAPs followed by HPV, it is known as a reflex test. Now if the reflex test shows HPV negative, then you do co-test every 3 yearly, but if HPV is positive, then colposcopy is done. That is colposcopic guided biopsy. For LCIL, again, age of the patient is seen. If the patient is 24 to 24 years, or the person is between 24 to 24 years, then annual PAPs is done, while for age more than 25 years, here again colposcopy is done. After performing a colposcopic biopsy, the report comes as SIN1, SIN2 and SIN3. For invasive cervical cancer, right, it is a squamous cell cancer. And let us see its staging quickly. Right, cervical cancer staging. Stage 1A is microscopic, B is macroscopic, right. 1A is divided into 1A1, which is less than 3 mm, and 1A2, which is 3 to 5 mm. 1B is again divided into 1B1, 1B2 and 1B3. 1B1 is less than 2 centimeter. This is sorry. 1B1 less than 2 centimeter, then 2 to 4 centimeter, and 1B3 is more than 4 centimeter. Stage 2, A is involving upper 2/3 of vagina, and 2B is involvement of parametrium. Then stage 3 is divided into 3A, 3B and 3C. 3A is lower 1/3 of vagina, B is pelvic wall, that is ureter will be involved, leading to hydronephrosis. And C is further divided into 3C1 and 3C2. C1 is pelvic lymph node and 2 is para-aortic lymph nodes. Now stage 4 is 4A and 4B. 4A is involvement of bowel and bladder, while B is involvement of the inguinal lymph nodes. Right. Now if you talk about its management, it is very easy. For stage 1A1, the treatment is simple hysterectomy or transabdominal hysterectomy. For stage 1A2, modified radical hysterectomy or Verdheim's hysterectomy is done. Up till stage 2B, radical hysterectomy or Meeks hysterectomy is done. This is type 1, type 2 and type 3 hysterectomy. Right. Beyond stage 2B, chemotherapy and radiotherapy is the treatment of choice. For stage 4, palliative treatment is done. Now, fertility preserving surgery can be done if the family is incomplete, and it can be done or performed up to stage 1B1. So the surgery is radical trachelectomy, where we remove the cervix and the upper vagina. Right. The conditions are, it should be less than stage 1B1 or the size is less than 2 centimeters. For chemo and radio, it is stage more than 2B2 or size is more than 4 centimeters. Now for radiotherapy, what we do is that tandem source is kept here, and from the cervix 2 centimeter above and 2 centimeter lateral there is a point A, while 5 centimeter lateral is point B. Right. At point A, 80 grays of radiation is given, and at point B, 60 gray radiation is given. Right. That is all you need to know in cervical cancer. Moving forward, the next topic is ovarian pathologies. So first let us look at the benign ovarian pathology, starting with anovulation. Right. Anovulation is detected by the progesterone challenge test, and it includes pregnancy, obesity, PCOS, which is the most common cause, dysregulation of hypothalamic and pituitary and ovarian axis, then premature ovarian failure, thyroid disorder and eating disorder. Right. So there is a condition called as functional hypothalamic amenorrhea. So here what happens is that severe caloric restriction and increase energy expenditure with or without stress. So what happens? It leads to decrease in leptin due to decreased fat and increase in cortisol. This leads to decreased pulsatile release of GnRH causing a decrease in LH, FSH and estrogen. Right. So functional hypothalamic amenorrhea is usually associated in patients who have eating disorders like anorexia nervosa and female athletes. There is a triad seen in female athletes, which is known as the female athlete triad, where there is a decrease in calorie intake, decrease bone mineral density and menstrual abnormality. This is female athlete triad. Now let us talk about PCOS, right? So it is polycystic ovarian disorder. What happens is that there is increased insulin leading to insulin resistance. This causes an increase in LH to FSH ratio. Also, what happens is that the androgens are increased. So increased androgens from the theca cells, they hamper the follicular growth. Right. So what happens is that the follicle are not able to mature properly, and this leads to the formation of cysts. So cysts are nothing but unmatured follicles. Right. So if you see in the Rotterdam criteria, more than 2/3 of the following factors are required. So first is the clinical diagnosis, where there is amenorrhea or oligomenorrhea. Second is the ultrasound criteria, where in ultrasound there are more than 12 cysts, right, with an enlarged ovary. You can see an enlarged ovary and more than 10 mm size of the cyst. Also, the cysts are arranged peripherally, and this is known as the necklace appearance or a garland appearance, but this is not a characteristic of the Rotterdam criteria. Another thing that you note in the ovary is that the bulky ovary will have an echogenic stroma. Right. This is also not part of a Rotterdam criteria. Then the third part of the Rotterdam criteria is hirsutism, right, which is calculated or given a score by Ferriway-Gallman score, and a score of more than 8 is suggestive of hirsutism. So if any 3 of the following are present, then we can make the diagnosis of a polycystic ovarian disorder. Now PCOS, it is associated with hair and syndrome, where acanthosis nigricans, insulin resistance. Also what happens is that the follicles, they do not rupture, hence they lead to infertility. Right. There is also increased risk of endometrial cancer due to unopposed action of estrogen from repeated anovulatory cycles. For treatment, right, the drug of choice are OCPs. For treatment of hirsutism, you can give anti-androgens, right, like the 4th generation progesterone like cyproterone acetate. And for infertility, clomiphene citrate and letrozole can be given. Clomiphene is preferred in postmenopausal women, while letrozole is preferred in women of reproductive age group. That is PCOS in a nutshell. Next, we'll be talking about the ovarian cyst. The most common ovarian cyst is a follicular cyst. It occurs due to increased estrogen that causes distension of the Graafian follicle. Right, since there is increased estrogen, it is also associated with endometrial hyperplasia. Next is a thecal uterine cyst. It is associated with conditions where there is increased HCG, like we studied in choriocarcinoma, where there are bilateral thecal uterine cysts. right? In early pregnancy as well, thecal uterine cysts can be seen, which maintains. In early pregnancy also, unilateral thecal uterine cyst can be seen. Now let us study about some ovarian tumors. So the ovarian tumors are basically classified into epithelial tumors, germ cell tumors and sex cord tumor, right? So epithelial tumors are nothing but tumors of the surface epithelium, while surface of the egg would be the germ cell tumor, and follicle and stroma would cause sex cord and stromal tumors. So let us begin by studying about the epithelial tumor. So first is a serous cyst adenoma. It is benign and it is the most common ovarian tumor. Next is a mucinous cyst adenoma. It is also benign, but there are multiloculated and large cysts. So serous cyst adenoma would be a simple cyst, while mucinous will have loculations, right? Mucinous cyst adenoma is also lined by the mucus secreting epithelium, and hence it can result in pseudomyxoma peritonei, right, which is nothing but intraperitoneal accumulation of mucinous material. Then next is a Brenner tumor. It is also benign. It is a solid and yellow tan tumor. What you need to know is that it has coffee bean nuclei, right? It has Walther cell nests and it is a transitional cell tumor. Next is serous carcinoma. This is the most common ovarian neoplasm and it has the presence of Samoma bodies. Samoma bodies are nothing but dystrophic calcification. Mucinous carcinoma, it is a rare tumor, right, and it may be metastatic from appendiceal or other GI tumors. Next is a clear cell tumor. It is associated with DES exposure, and this question was asked, I don't remember the year, but what was asked, that clear cell tumor is a type of what tumors? The answer was epithelial tumor, right? After doing the epithelial tumors, let us look at the germ cell tumors. So the first tumor is a mature cystic teratoma. It is commonly called as a dermoid cyst. It is a benign tumor and it is the most common ovarian tumor in young females, right? So what is it? It is a cystic mass with all three elements, that is the endoderm, mesoderm and the ectoderm, right? So you can see the ectoderm derivatives like hair, teeth, sebum, along with mesenchymal derivatives and the endodermal derivatives. Now it may be painful secondary to ovarian enlargement and torsion. So if it leads to torsion, it may present with pain. Now what happens is that a monodermal form with thyroid tissue, right? It is known as struma ovariae. That is, it presents with colloid like substances, right? That is the presence of a thyroid or an ectopic thyroid in the ovary. That is called struma ovariae. And since there is thyroid tissue, it is associated with hyperthyroidism. Malignant transformation is rare in mature cystic teratoma, and if it transforms, it usually leads to squamous cell cancer. Next is an immature teratoma. It is malignant and aggressive. It contains fetal tissue and neuroectoderm, right? It is commonly diagnosed before the age of 20 years and it is typically represented by immature or embryonic like neural tissue. Next is dysgerminoma. This is homologous to the male seminoma of the testes that we did. It is also a malignant tumor and it is the most common malignant tumor and it is most commonly seen in adolescents, right? So it has sheet of cells that give the appearance of a fried egg, so it is called as a fried egg appearance, right? And the tumors are positive for HCG and LDH, just like seminoma. Next is a yolk sac tumor. It is also called as endodermal sinus tumor. It is malignant and aggressive, right? On gross it is yellow and friable with hemorrhagic areas in between. Now 50% of yolk cell tumors have Schiller-Duval bodies, right? They resemble the glomeruli, and this was asked in INI-CET this year. The tumor marker associated is alpha fetoprotein. It occurs in children and young females. So this completes the germ cell tumor. Next category is the sex cord stromal tumor. So the first type is a granulosa cell tumor. This is the most common malignant sex cord stromal tumor, right? It is found in females in their 50s. It produces estrogen, right? This is a very important point, that it is an estrogen producing tumor. It may produce progesterone as well. So patient usually present with postmenopausal bleeding, right? Postcoital bleed is usually cervical cancer, while postmenopausal bleed is an ovarian cancer. Then also it can be associated with endometrial hyperplasia, as there is increased estrogen, right? And sexual precocity in pre-adolescence along with breast tenderness. On histopath, we can see the Cole-Exner bodies, and this was again asked this year in INI-CET or NEET, right? So what are Cole-Exner bodies? They are nothing but there are granulosa cells which are arranged haphazardly around a collection of eosinophilic fluid, right? So this is eosinophilic fluid, as it is pinkish in color, and the cells surrounding it are the granulosa cells. So they resemble a primordial follicle and are called as the Cole-Exner body. The tumor marker associated is inhibin. The next tumor is fibroma. It is benign and it consists of bundle of spindle shaped fibroblast. It is associated with Meeks syndrome, right, which is a triad of fibroma, ascites and pleural effusion. If apart from fibroma or thecoma, any other tumor is seen along with pleural effusion and ascites, it is known as pseudo-Meeks syndrome. Next is thecoma. It is also benign. It may produce estrogen and it usually presents with abnormal uterine bleeding in postmenopausal female, right? Next is Sertoli Leydig cell tumor, again a benign tumor. It is very small and appears grey to yellow brown in gross. It resembles testicular histology with tubules and cords lined by pink Sertoli cells, right? It may produce androgens and it leads to virilization in females, that is hirsutism, male pattern baldness, clitoral enlargement, etc. Now CA-125 is used for the prognosis of epithelial tumors or ovarian tumors, but they are not useful for the diagnosis, right? Since we are studying ovarian tumor, I think it's better to study the testicular tumor as well, because they are almost same, right, and they are homologous to each other. You can find it on page 667 in your 21st edition first aid, or you can just look in the index, right, and read testicular tumor here only, right. So testicular tumor also will be germ cell tumor, where the tumor involves a developing sperm, while Leydig and Sertoli cells, that is the sex cord or stromal tumor we just read. So just look at it quickly and find the similarities with its counterpart, that is the ovarian tumor, right. So it is basically divided into two parts, germ cell tumor and non-germ cell tumor. Germ cell tumor are further divided into seminomatous germ cell tumor and non-seminomatous germ cell tumor, right. So seminoma, which was dysgerminoma in ovary, embryonal carcinoma, yolk sac, choriocarcinoma and teratoma. These were all same. Then non-germ cell tumor, which is the sex cord stromal tumor, that includes the Leydig, and the Sertoli cell tumor like the ovarian. So seminoma like dysgerminoma is a malignant tumor. It is painless and it causes homogeneous testicular enlargement. Right. It is the most common testicular tumor and it does not occur in infancy. So what you will see, there are large cells in lobules with watery cytoplasm. Again, the histopath would be same as dysgerminoma, showing a fried egg appearance. There will be increased placental ALP, right? There is also increased LDH and it is a radiosensitive tumor. It has late metastasis and the prognosis is excellent. Now, non-seminomatous is embryonal carcinoma. It is malignant and it is painful, right? Because there will be areas of hemorrhage and necrosis. Pure embryonal carcinoma are rare. It is usually seen as a mixed tumor with other tumor types. It is associated with increased HCG and a normal alpha fetoprotein, right? Alpha fetoprotein may be increased when it is a mixed variety. The next is yolk sac tumor, which is also called as embryonal sac tumor, right? It will have Schiller-Duval bodies. This is just a revision, and increased AFP, right? And it will be seen in children less than 3 years of age. Next is choriocarcinoma. It is malignant with disordered syncytiotrophoblasts and cytotrophoblast. It has hematogenous mets to the lungs. We read the cannonball mets, and there is increased HCG. And teratoma, which is the mature teratoma, it may be malignant in males. It was benign in females, but it may be malignant in males. Remember MM. Then non-seminomatous, non-germ cell tumors are Leydig cell tumors. They are mostly benign, right? Leydig cell tumors will have rinky crystals, which is nothing but it is an eosinophilic cytoplasmic inclusion. It produces androgens or estrogens and it leads to precocious puberties and gynecomastia. Then Sertoli cell tumor is also called as androblastoma and it arises from the sex cord stroma. It is also mostly benign. Then the next is primary testicular lymphoma. It is malignant and aggressive and it is typically diffuse large B cell lymphoma and it is the most common cancer in older males. Right. Remember one more thing, that extragonadal germ cell tumor, they are usually midline and the most common site for them is retroperitoneum, followed by mediastinum, followed by pineal, followed by suprasellar region. While in children, the most common site or the most common extragonadal germ cell tumor will be a sacrococcygeal teratoma. Another important point is regarding the management. So it is divided into the management of seminomatous germ cell tumor and non-seminomatous germ cell tumor, right? So for stage 1, that is the involvement of testes. Stage 2, involvement of testes with structures below the diaphragm. 3 is above the diaphragm and 4 is distant mets. So for seminomatous germ cell tumor, surveillance, or a single agent chemotherapy with platinum compounds is sufficient. while for non-seminomatous germ cell tumor, BEP regimen, 1 cycle is given, which is bleomycin, etoposide and platinum compounds, right. For stage 2, in seminomatous, radiotherapy is done, which is given in a dog field region, that is along the aorta, right, inverted Y or para-aortic. And in non-seminomatous, BEP is given for 3 cycles with retroperitoneal lymph node dissection. For stage 3, radiotherapy followed by chemotherapy, and here again BEP for 3 cycle along with retroperitoneal lymph node dissection, while in stage 4 both are same, that is chemotherapy with or without metastatectomy. Right. So now the tumor markers were asked in this year NEET, right, LDH for seminoma, HCG for choriocarcinoma, AFP for yolk sac tumor. Another question on seminoma was asked that in patients with seminoma, they develop Hodgkin's lymphoma that leads to a paraneoplastic syndrome causing cerebellar ataxia. So the answer was Hodgkin's lymphoma. This was asked last year in INI-CET. So what happens is that the Hodgkin's lymphoma, it causes cerebellar ataxia, which is encephalomyelitis, right, which is due to anti-TR antibody, right. It was asked in NEET or INI-CET in 21. So yeah, the paraneoplastic syndromes are very important. We covered it in the recipe. You can revise it again. So now let us move back to the Gynae cancers, right. And the next topic that we will be doing are the uterine pathologies. So let us start with the non-neoplastic conditions. First is adenomyosis. It is the extension of the endometrium or the endometrial tissue into the myometrium, right. It is usually due to hyperplasia of the basal layer of endometrium. It presents with abnormal uterine bleed or heavy menstrual bleeding, and the uterus will be uniformly enlarged, soft, globular, and ultrasound will show a salt and pepper appearance or the Venetian blind sign, right, with loss of endometrial myometrial junction. This is very characteristic of adenomyosis. The next is Asherman syndrome. Yeah, but before that, for treatment of adenomyosis, we can give GnRH agonists, right, or if it is unresponsive, then hysterectomy can be done. The next condition is Asherman syndrome. It is nothing but it is the adhesion or fibrosis of the endometrium, right. The patient presents with decreased fertility, recurrent pregnancy loss, abnormal uterine bleed and pelvic pain. It is usually associated or seen after dilatation and curettage of intrauterine pregnancy. Next is endometrial hyperplasia. So what happens is that there is abnormal endometrial gland proliferation due to increased estrogen, right. It increases the risk of endometrial cancer, especially with nuclear atopia. It presents with postmenopausal bleed and it is associated with or its risk is increased with anovulatory cycles, right? Why? Because in anovulatory cycles there is no progesterone, and the increase in estrogen leads to the endometrial hyperplasias. It is also associated with hormone replacement therapy for the same reason, PCOS and granulosa cell tumors. That is all the condition in which there is increase in estrogen. So we read in the last class that for management of endometrial hyperplasia, if atypia is present, then the management will be hysterectomy. But in cases where there is no atypia, or that is endometrial hyperplasia without atypia, we can give progesterone, because progesterone causes atrophy of the endometrium, right? Next condition is endometriosis. Yeah. So what happens is that the endometrial glands or stroma, when present outside the endometrial cavity, right? If it is present in the myometrium, then it is called as adenomyosis, while if it is present outside the uterus, it is called as endometriosis. The most common site for endometriosis is the ovary, followed by pelvis, then peritoneum, right? It is characterized by yellow-brown powder burn lesions. In ovary, it appears as endometrioma, which is nothing but blood-filled chocolate cysts, right? So it may be due to retrograde flow of the menstrual fluid, right? Metaplastic transformation, and then transformation of the endometrial tissue via the lymphatic system. So what is the most important clincher or the buzzword is that the patient presents with cyclical pain, right? This is very important, and this is a clue towards endometriosis. Why? Because suppose there is an endometrioma in the ovary, right? So during the time of menses, what happens is that there is increase PGF2 alpha, which is responsible for the pain of the menses. Now this PGF2 alpha will also be released from the endometrioma present in the ovary, hence there will be extensive pain in the abdomen, that is called as a cyclical pain. So what you do is that you perform an ultrasound on the patient, and when you look at the ovaries, you can clearly see the endometrioma as cystic spaces with fine echogenic dots inside it, right? So this is nothing, this is a blood filled cystic ovary, or what you better known as the chocolate cyst, right? The other clinical features are dyspareunia, dyschezia. Dyschezia is pain with defecation. There can be infertility if the cysts are too large in size. And for management of endometriosis, NSAIDs can be given for pain relief, OCP and progestins. Then GnRH agonist or GnRH antagonist can be given, and finally, if nothing works, then laparoscopic removal is the final treatment modality for endometrioma. Now coming to the next topic, that is endometriitis. It is nothing but it is an inflammation of the endometrium, right? So it is associated with retained products of conception, post delivery, miscarriage or abortion, or with foreign bodies like IUD. The retained material, what it does is that it acts as a nidus for the bacteria from the vagina or the GI tract, and if the infection is chronic, it will show plasma cells on the histology. For treatment, we give gentamicin plus Glinda with or without ampicillin. Now let us move ahead to the endometrial neoplasms, right? So endometrial carcinoma were the most common gynecological tumors in the US, right? Patient will present with irregular vaginal bleed. There are of two types. First is endometrioid, which is caused due to unopposed action of the estrogen, right? And it is associated with obesity and metabolic syndrome. The histology will show abnormally arranged endometrial glands, and it is also associated with P10 mutation. The next variety is serous type, which is seen in postmenopausal females, and it is associated with endometrial atrophy, right? It will also have presence of psammoma bodies, and it is characterized by papillae and tuft. This is also known as type 1 tumor. This is known as type 2 endometrial tumor. The next is leiomyoma, which is a fibroid. It is the most common tumor seen in females. It often presents with multiple, discrete tumors. They are benign smooth muscle tumor, and the malignant transformation can lead to the production of leiomyosarcoma. Leiomyosarcoma is a rare tumor, right? So fibroid, it is an estrogen sensitive tumor. That is, the tumor size will increase in conditions where the estrogen is increased, that is in pregnancy, and it will decrease with menopause. The peak occurrence is between the age of 20 to 40 years. It may be asymptomatic, or it may cause abnormal uterine bleeding, right? Severe bleeding may also lead to iron deficiency anemia. The characteristic feature of leiomyoma is its whorled appearance. On histopath, the whorled appearance is due to the smooth muscle bundles, and they have discrete borders. Leiomyosarcoma is the proliferation of smooth muscle arising from the myometrium, right? It arises de novo and usually in postmenopausal females. They are usually a single lesion with areas of necrosis. So this completes the discussion on gynae cancers. For details, you could also visit the video on gynae cancers by clicking in the link here and also in the description box. Now let us move ahead with our talk, and the next topic that we'll be covering is the breast. So breast is a modified sweat gland. The unit of breast is TDLU, or the terminal duct lobular unit. It opens into the lactiferous ducts and finally into the nipple. It is surrounded by the stroma. For a detailed discussion on breast, I have a PDF available, which is the breast integrated, covering both the anatomy and surgery of the breast, right? You can check it out. For discussion purposes or due to the limitation of time, we'll be sticking to what is mentioned in the first aid. So the first pathology that we'll be studying are the benign breast diseases, and in that the abnormal development and involution, that is the fibrocystic disease of the breast. So it is the most common pathology seen in premenopausal women, that is between 20 to 50 years of age, and it presents with premenstrual breast pain, right? Remember, with endometriosis there were cyclical pains, while with fibrocystic disease there is also cyclical breast pain, which is just before the menses, right? It may present with lumps which are bilateral and multifocal. It is of two types. First is sclerosing adenosis, where there is fibrosis of the acini and stroma, and it is associated with calcification, right? There is a slight risk of increase of cancer. Next is epithelial hyperplasia, where what happens is that the cells in the terminal ductal or lobular epithelium undergo hyperplasia, and here there is increased risk of carcinoma with atypical cells. Then next are some inflammatory process like fat necrosis. It is usually benign, painless lump due to injury to breast tissue. On mammography, we can see a calcified oil cyst, right? And on biopsy, we can see giant cells and necrosis of fat. Next is lactational mastitis. It occurs due to breastfeeding, and there is increased risk of bacterial infection through the cracks in the nipple, and the most common organism is Staph aureus. For treatment, antibiotics are given and breastfeeding is continued. Then some benign tumors. First is fibroadenoma. It is the most common tumor in female less than 35 years of age. It is a small, well-defined mobile tumor. It is also called as breast mouse, right? It is composed of fibrous tissue and glands. It increases with estrogen, that is, it increases in pregnancy and prior to menstruation, and there is no risk of increased cancer. Next is a phyllodes tumor. It is a large mass as compared to fibroadenoma, right? It is composed of connective tissue and cysts. The characteristic features are leaf-like lobulations, right? That is why it is known as a phyllodes tumor. It is most commonly seen in the 5th decade, and some of them may even become benign. Next benign condition is an intraductal papilloma. Right. So intraductal papilloma, it is a small fibroepithelial tumor within the lactiferous ducts. It is the most common cause of nipple discharge that can either be serous or bloody, right? It has again a slight risk of cancer. The next condition is gynecomastia. It is breast enlargement in males. Why? Due to increased estrogen, right, as compared with the androgen activity. It is physiologically seen in newborns, then pubertal males and elderly males. But it may also persist after puberties. The other causes of gynecomastia include cirrhosis, hypogonadism, right? We read in Klinefelter syndrome. Then testicular tumors and drugs like spironolactone. Very important question. Hormones, cimetidine, finasteride and ketoconazole. These all drugs are very important. So the next topic is breast cancer. It is another important cancer after cervical cancer, as breast cancer is the most common cause of cancer in females overall, right? So it commonly occurs in postmenopausal females, and it often presents as a palpable hard mass. On the mammography, we can see breast cancer as a radiodense structure with spiculated margins, and some microcalcifications can also be seen. So this is most likely a BIRADS 5. It is most common located in the upper outer quadrant. Then it can become fixed to the pectoral muscle, the fascia, Cooper's ligament that appears as dimpling, lactiferous duct involvement appears as nipple retraction, and it can be fixed to the skin, where the involvement of subdermal lymphatics lead to the famous peau d'orange or the orange peel appearance. This question was asked this year in NEET, right? What is important to note is that the fixity or the involvement of the pectoral muscle and Cooper's ligament or lactiferous ducts, right? These are not included in the staging of breast cancer. That is, involvement does not upstage the breast cancer, right? Let us study breast cancer in a bit detail. So, the risk factor for breast cancer is increased age, family history, that BRCA1 and 2 mutation, and all the conditions that increase the estrogen, like history of atypical hyperplasia, nulliparity, early menarche, and late menopause. Breastfeeding decreases the risk of breast cancer before 30 years of age, while it has a slight increased risk after 30 years of age. Hence, it is advised to start breastfeeding before the age of 30 years, that is to have a family, right? Talking about the staging of breast cancer, TIS is DCIS or ductal carcinoma in situ and Paget's disease, right? The prognostic scoring for DCIS is Van Nu scoring. This is important, you need to know the name. Then T1 is tumor less than 2 cm. It is further divided into MI, stage T1A, T1B, T1C. MI means microscopic involvement, that is less than 1 mm, A is 1 to 5 mm, B is 5 to 10 mm, while C is 10 to 20 mm. Stage 2 is the size of the tumor 2 to 5 cm, 3 is more than 5 cm. Stage 4A is the involvement of chest wall, that includes the serratus muscle, intercostal muscles and the ribs, while very important point is that pectoralis muscle is not considered as involvement of chest. B is involvement of skin, that is the peau d'orange appearance, including ulcers and satellite lesions. C is involvement of skin with chest wall, and D is inflammatory breast cancer. What is not included is pectoralis in the involvement of chest wall and dimpling and retraction in skin involvement. This is not included. The most important prognostic factor is the involvement of the axillary lymph node. So, the lymph nodes are along the axillary vessel and they are divided into 3 stations by the pectoralis minor muscle. The lateral group of lymph nodes are station 1, behind the pectoralis are station 2 and medial group are station 3. So, N1 is the involvement of axillary and rotor's lymph node, which is station 1 and station 2 respectively. N2A is a fixed lymph node, while B is involvement of internal mammary lymph node. N3A is the involvement of infraclavicular lymph node. B is the involvement of internal mammary and axillary lymph node, and C is the involvement of supraclavicular lymph node. Very important point to note is that if contralateral lymph node is involved, it is taken as METS or M1 stage. Now here only we quickly look at the management. Up till stage T2, it is called as early breast cancer, and the treatment of choice is surgery, which includes either a breast conservation surgery or a modified radical mastectomy. For patients undergoing breast conservation surgery, radiotherapy is mandatory, and chemotherapy can be added based upon the hormone status of the tumor. The chemotherapy or the regimen that is used is the CAF regimen, that is cyclophosphamide, adriamycin and 5-fluorouracil, or CMF regimen, where in case of adriamycin methotrexate can be used. Stage T3 is called as locally advanced breast cancer, where the management is neoadjuvant chemotherapy followed by a breast conservative surgery or a modified radical mastectomy. For M1 disease, palliative treatment is given. Another point to know is that MRM is of 3 types. First is Auchincloss, where pectoralis minor is retracted, and other are Scanlon and Patey's, where pectoralis minor is cut. Talking about screening of breast cancer, screening is done by mammography if the age is 40 years and BI-RADS score is given on mammography, which is breast imaging reporting and data system. The BI-RADS is as follows. BI-RADS 1 is normal, BI-RADS 2 is probably benign, BI-RADS 2 is benign with the risk of malignancy being 0%, BI-RADS 3 is probably benign with the risk of malignancy less than 2%. BI-RADS 4 is probably malignant with a risk of 2 to 95%. 5 is malignant with a score of or a risk of more than 95%, and BI-RADS 6 is a biopsy proven breast cancer. So, for BI-RADS 1 and 2, only routine screening is advised. For BI-RADS 3, a 6-monthly follow-up is advised, while for BI-RADS 4 and 5, biopsy needs to be done. For women of age 35 years, screening is done if family history is positive, and they are again followed by mammography. For females in the age group of 25 years, either having a BRCA mutation or primary relatives with BRCA mutation, the screening is done with an MRI. Investigation of choice for breast cancer is a true cut biopsy. This is an example of an incisional biopsy, right? But for staging, the investigation of choice changes to PET-CT, while the gold standard for breast cancer is an excisional biopsy. Next, talking about the molecular subtypes, it is luminal A, luminal B, HER2 new enriched, and triple negative breast cancer or basal type. The molecular classification is based on ER status or estrogen receptor status, progesterone receptor status, and HER2 new. Luminal A is ER/PR positive while HER2 new negative, and luminal B is triple positive. HER2 new enriched will be positive only for HER2 new, while the basal type or a triple negative will be negative for all three. So, in case of a triple negative or a basal type, the management is a PD-L1 inhibitor, that is atezolizumab, while for HER2 new enriched, the management or the monoclonal antibody given is a trastuzumab or a pertuzumab. While talking about ER/PR positive, so in these cases hormone therapy, so for ER/PR positive tumors, hormone replacement therapy is given, that is tamoxifen, which can be given for a period of 10 years because the side effect is that it increases the risk of endometrial cancer, right? Talking about newer drugs, palbociclib can be given, in ERPR positive tumors. Now let us review some non-invasive conditions of the breast. So first is ductal carcinoma in situ. In ductal carcinoma in situ, the duct is occupied by the neoplastic cells, and here this is engorgement of a blood vessel. So it arises from ductal atypia, and it is often seen as microcalcification on mammography. It is an early malignancy, that is, the basement membrane is not invaded and it usually does not produce a mass. A subtype of DCIS is comedocarcinoma. Right, here the cells have a high grade nuclei along with dystrophic calcification with central necrosis, as we can see in the image, areas of necrosis. Next is Paget's disease of the breast. So it is an extension of an underlying DCIS or an invasive breast cancer into the lactiferous duct, right, and thereby into the contiguous skin of the nipple, right. It occurs as an eczematous patch over the nipple and the areola skin. Paget cells are basically intraepithelial adenocarcinoma cells. Next is lobular carcinoma in situ. It is associated with decreased E-cadherin expression, right. There is again no mass or calcification, and it is just an incidental finding on the biopsy. It increases the risk of breast cancer in either of the breast, right. So DCIS increases the risk of cancer in the same breast, and that too in the same quadrant, while the lobular carcinoma in situ, it will increase the risk in either of the breast. So this completes the non-invasive condition. Talking about the invasive condition, the first entity is the invasive ductal carcinoma. So it is a firm fibrous rock hard mass with a sharp margin and a small glandular duct-like cell in desmoplastic stroma. Right, it is the most common type of invasive ductal carcinoma. Second is the invasive lobular carcinoma. As the carcinoma in situ, it is also associated with decreased E-cadherin expression, right. So that means that there is an orderly row of cells. The appearance is known as Indian file pattern, right, and here there is absent desmoplastic reaction. It is often bilateral and multiple in the same location. Next is medullary carcinoma. So here there are large anaplastic cells that grow in sheaths, and it is associated with lymphocytes and plasma cells. It is basically a well circumscribed tumor, and the differential for medullary carcinoma is a fibroadenoma. Next invasive cancer is inflammatory breast cancer. So here what happens is that there is invasion of dermal lymphatics leading to breast pain with warm, swollen and erythematous skin, especially around the hair follicles, right. Therefore it is known as inflammatory breast cancer, and it causes the typical Pure-d'Orange appearance, which was asked this year in NEET 2020, that Pure-d'Orange is due to the involvement of subdermal lymphatics. The prognosis of inflammatory breast cancer is poor, that is only 50% 5-year survival rate is there, and it is often mistaken for mastitis, right, because of the inflammatory component or Paget's disease. Also, there is no palpable mass, hence the differentiation is poor. Now, all the types of invasive breast cancer can be either of a tubular subtype, which is the presence of well differentiated tubules with absent myoepithelium, or they can be of mucinous subtype where there is abundant extracellular mucin, and mucinous is more commonly seen in older females. So that completes the discussion on breast and its pathology. The next topic we are studying are the penile pathologies. So first is Peyronie's disease. It is the abnormal curvature of the penis here. Why? Due to the presence of fibrous plaques in tunica albuginea, right? It is associated with repeated minor trauma during the intercourse, and it causes pain, anxiety, and even erectile dysfunction. So for management, the surgical repair is done with collagenase injection. Once the curvature stabilizes, surgical repair is done with collagenase injection, and Nesbitt's procedure is done where bites are taken on the opposite side to the curvature, which leads to fibrosis of the sutures and helps in resolution of the curvature. It is distinct from penile fracture, because in penile fracture what happens is that there is rupture of corpora cavernosa due to forced bending, right? While Peyronie's is the deposition of fibrous plaques in the tunica albuginea. The next topic is ischemic priapism. It is nothing but painful sustained erection for more than 4 hours. It is associated with sickle cell disease. Why? Because the sickled RBC blocks the venous drainage of corpora cavernosa, right? Then it can be due to some medications, that is the adverse effects of medications used for treating ED like sildenafil. Also trazodone can also cause ischemic priapism. For management, immediate treatment is required, right? So what we do is corporal aspiration along with intracavernosal injection of phenylephrine and surgical decompression to prevent the ischemia. They include the Winter shunt, Greyhack shunt, Quackle, and Berry shunt. The next topic is squamous cell carcinoma of the penis, right? The precursor lesion for squamous cell carcinoma is Bowen's disease, which is in the shaft and which presents as leukoplakia, and erythroplakia of Kehrat, which is present in the glands, right? So Bowen's disease is leukoplakia, that is, it is a white patch, while erythroplasia of Kehrat, as the name suggests, is erythroplakia, and it will present as a red patch, as we can see in the image. This is erythroplakia of Kehrat. Then bovinoid papulosis is the carcinoma in situ of unclear malignant potential and presents as reddish papules, right? It is associated with uncircumcised males and HPV infection. Then Buschke-Lowenstein tumor, it is a slow growing cancer of penis, and the most common cause of death in penile cancer is erosion of femoral vessels. Next are some scrotal and testicular conditions. So the first condition is cryptorchidism, which is the failure of descent of one or both testes, right? So this lead to impaired spermatogenesis, as we read that the Sertoli cells are temperature sensitive, and increase in temperature is associated with decreased sperm production, right? But they will have a normal testosterone level, as Leydig cells are not affected by the temperature, right? So it is associated with increased risk of germ cell tumors. The risk factor for cryptorchidism are prematurity. The hormonal profile will be decreased inhibin B due to increased temperature, increased FSH and increased LH, while decreased testosterone. This is seen in bilateral cryptorchidism. In unilateral orchidism, the testosterone remains normal. So most of the cases of cryptorchidism resolve spontaneously, but if not, then orchidopexy is done before the age of 2 years to prevent infertility. The next topic is testicular torsion. So it is the rotation of testes around the spermatic cord or a vascular pedicle, right? It is commonly seen in the age group of 12 to 18 years, and it is associated with a horizontal positioning of testes, which is called a bell clapper deformity. Right. So normally the testis is positioned like this, but in cases of torsion it will be a bit higher up. This is known as Deming sign, right? Then there may be an inciting event leading to torsion, like trauma, or it may be a spontaneous event, right? It is characterized by pain highlighting testes, and French sign is decrease in pain on lifting the pelvis, on lifting the testes. So this is not true. So French sign is negative. Then for management, orchidopexy should be done within 6 hours, right? Manual detorsion can be performed if surgical option is unavailable in the time frame. Now, if the testes is not viable, then it is better to perform orchidectomy. Also, prophylactic contralateral orchidopexy is done in the contralateral testes to prevent the risk of subsequent torsion in the contralateral testes. The next topic is varicocele. It is a dilated vein in the pampiniform plexus, right, due to increase in venous pressure. The most common cause being scrotal enlargement in adults means, right? We read that it is more common on the left side than the right side because of increased resistance from the left gonadal vein as it drains into the left renal vein. This can also lead to infertility because it causes increase in temperature. So for diagnosing, the investigation of choice is Doppler. The patient is asked to stand or perform a Valsalva maneuver, right, because varicocele is augmented on Valsalva. On ultrasound we can see this is the testes, and here these are the dilated veins, right? If you perform a Doppler, you will see the color in the veins, and there will be augmentation or increase in the diameter of veins when you perform a Valsalva. Right, that is how varicocele is diagnosed. Also, very important point to note is that there is no translumination because it is not a cyst. It is just dilated veins, and veins will contain blood. Therefore, they will not transilluminate. For management, only symptomatic cases are managed, right? So we can either do surgical ligation or embolization if symptomatic. And the methods are INI-CET method, it is an inguinal method, and an open method. Then Paloma procedure is high ligation, so vein, and it is a retroperitoneal method. Then Notes procedure can be done, which is a transvesical procedure. The next condition is hydrocele. So hydrocele is of two types, congenital and acquired. Congenital hydrocele is the most common cause of scrotal swelling in infants, and it is due to the incomplete obliteration of processus vaginalis, and it resolves spontaneously by 1 year. If it does not, then the treatment is herniotomy, which is done at 2 to 3 years of age. It is a communicating hydrocele and presents as an inguinoscrotal swelling. Talking about acquired hydrocele, it is non-communicating, right? There is scrotal fluid collection which can be secondary to an infection, tumor or trauma. If blood is present, then it is called as a hematocele, right? Here we can see two types of hydrocele. This is the vaginal hydrocele, and if it extends up till the superficial inguinal ring, then it is called as the infantile hydrocele. For management of hydrocele, like if it is small, then Lord's plication is done, while Jabulus procedure is the treatment of choice for a large hydrocele where eversion of sac is done, while for infantile the management is simple eversion and excision. Then a variant is encysted hydrocele of the cord, where only the middle part of the processus vaginalis is affected or it is patent, rest the proximal and distal are obliterated, and this condition is known as encysted hydrocele of the cord. Right. The next condition is spermatocele. So spermatocele is a cyst which is due to dilated epididymal duct or rete testes. Right. It is a paratesticular flocculent nodule. Right. So here you can compare all the figures. Hydrocele is nothing but a patent processus vaginalis. Then spermatocele is epididymal duct or rete testes enlargement. Then varicocele is the dilatation of the pampaniform plexus or vein, and testicular torsion is nothing but a high riding testes due to the twisting of vessels. Right. One thing I forgot to mention, that on Doppler in testicular torsion we will see absence of blood flow, and if this happens, then you need to perform surgical derotation within 6 hours, else the testes will not be viable, right? Next we will talk about epididymitis and orchitis. The most common cause are chlamydia trachomatis and Neisseria gonorrhoeae in young males, while in older males the most common cause are E. coli and Pseudomonas, right? It is also associated with UTI and BPH. They can also be due to autoimmune disorders like granulomas involving the seminiferous tubules. So epididymis is nothing, as the name suggests, it is an inflammation of the epididymis, and it presents with localized pain and tenderness over the posterior testes, right? Here the French sign will be positive, that is on scrotal elevation there will be a relief of pain, while for testicular torsion the French sign is negative, and this is how you differentiate between epididymitis and torsion. Also when you perform Doppler, right, first of all the testes would be enlarged in cases of epididymoorchitis because it is an inflammation, right, increase in size. Secondly, you will see the Doppler flow in the testes, while in torsion the testes would be high riding or it will be high up, and there will be absence of Doppler flow. It is very important to differentiate between epididymitis and torsion because one is a surgical emergency and other is managed just by giving antibiotics. The next condition is orchitis, and it is nothing but it is the inflammation of testes. So epididymitis usually lead to orchitis, hence epididymoorchitis is commonly seen when the patient presents with pain in the testes, and it is associated with mumps, right, and there is increased risk of infertility. It is rare in males less than 10 years. So that completes the penile pathologies and the scrotal pathologies. Now let us look at the next important topic, which is BPH, right. So BPH is the hyperplasia of the prostate, and it is benign, right? Benign prostatic hyperplasia. It affects the middle lobe, right? So this is the area of BPH. Now here what happens is that it has two components. First is a static component, that is due to testes, which converts to dihydrotestosterone with the help of 5-alpha reductase enzyme. This leads to increased stromal hyperplasia, right? Remember, it is hyperplasia and not hypertrophy. Due to stromal hyperplasia, there will be increased PSA. Very important point to note is that PSA would be increased total PSA as well as increased fraction of free PSA, right? Very important. Second is the dynamic component, where alpha 1A receptors are stimulated and they increase the smooth muscle tone, right? This leads to lower urinary tract syndrome or the LUTS. Hence, for the management of TURP, what we can do is we can give either 5-alpha reductase inhibitors or 1-alpha receptor inhibitors. The 5-alpha reductase inhibitor is finasteride, while 1-alpha receptor inhibitor is tamsulosin, terazosin, right? Terazosin is preferred in older patients where BPH is present with hypertension, while tamsulosin is given in younger patients. If the size is more or the symptoms are not relieved by giving the medical management, then surgical procedures are done. So what are the surgical procedures? First is TURP, that is transurethral resection of prostate, right? It can lead to a TURP syndrome after 4 to 6 hours, which is nothing but dilutional hyponatremia when we use 5% dextrose or distilled water. This can be prevented by using isotonic glycine, right? Then other processes are HOLEP, these are laser processes, and TULIP. In TULIP, the most common laser used is Nd:YAG, but if you talk about the best laser, then that is KTP laser, which is a green light laser that works at a wavelength of 532 nanometers. Other complications of prostate surgery, right? If you talk about the most common intraop complication, then it is in hemorrhage. The most common artery to bleed is Badenoch's artery, which is a branch of internal vesical artery, and the most common overall complication is retrograde ejaculation. If this does not work, then open surgery needs to be performed, that is Young's procedure and Millen's procedure. Then next is prostatitis. It is the infection of prostate, right? The causes are same, that is chlamydia and Neisseria in young males and E. coli and Pseudomonas in older males, right? It is also characterized by dysuria, frequency, urgency and low back pain, but the prostate will be warm and tender. The next topic is prostate adenocarcinoma. It involves the posterior lobe or the peripheral zone. It is associated with increased PSA, but very important point to note is that there is increase in total PSA, but there is a decrease in free PSA as opposed to BPH, where there was increase in free PSA as well, right? The investigation of choice is ultrasound guided truss biopsy, which is a 12-core biopsy, right? But for staging, again, the investigation of choice is PET-CT. Then very important prognostic score to know about the metastatic potential is the Gleason score. Here what we do is the most common pathology and the second most pathology is given a score between 1 to 5. So the score can range from minimum 1 to 1 to 5 plus 5. the most important prognostic factor for prostate cancer is the stage, right? Now, what you need to know is the management. This was asked in last year INI-CET or NEET, either of the two exams. So, in early prostate cancer, if the Gleason score is less than 7 or the life expectancy is less than 10 years, that is, the patient is more than 70 years of age, then nothing needs to be done, just active surveillance is sufficient. While if the Gleason score is high, that is more than 7, or patient is young, that is less than 70 years of age, then radical prostatectomy needs to be done, right? For locally advanced prostate cancer, that is more than stage 2B or more than 50% lobe involvement, right? Here brachytherapy is done using iodine 125 isotope and 68 to 70 gray radiation is given. For metastatic disease, either bilateral subcapsular orchidectomy is done, which is surgical castration, or medical castration is done using LHRH agonist like goserelin and degarelix. Since LHRH agonists are known to cause flare, the flare is decreased by adding anti-androgens like flutamide and abiraterone. For hormone resistant tumors, chemotherapy using paclitaxel is done and radiotherapy can also be given. Another very important point is Siplucel used in hormone resistant tumor. It is a T cell vaccine which is a CD54 extract, right? Then for bony mets, the most common type of bony mets in prostate is an osteoblastic met more than an osteolytic, right? It goes to the vertebral column by Bateson's plexus. This was asked this year in NEET. Bony mets would be characterized by low back pain and increased ALP levels. For bony mets, the management is strontium 89 and radium 223, which destroys the tumor by the means of alpha rays. Important, right? So this was asked that a patient has a Gleason score of less than 7, what would be the management? So the answer to that question was active surveillance, and this year they asked the question on Bateson's plexus. So you can see the importance of repeat questions as well. That's why I say that PYQs are very important. Anyways, this completes the reproductive pathology, and now let us review the reproductive pharmacology. But before digging into the core pharma, let's revise the controller hormones once again, which we know by heart by this time, right? So first we have the hypothalamus. It leads to the secretion of GnRH, right? GnRH will stimulate anterior pituitary to secrete LH and FSH. LH and FSH both act on ovary to secrete androgens, that is the androstenedione and testosterone. The androgens undergo aromatization and they convert into estradiol and estrone, also estriol, right? And finally, they cause gene expression in estrogen responsive cells. In the males, the LH will act on the Leydig cells of the testes to produce testosterone, and testosterone converts into dihydrotestosterone by 5-alpha reductase, and they both act on androgen receptor complex and cause gene expression in the androgen responsive cells. So what happens is that clomiphene, it stimulates the GnRH by blocking the negative feedback, right? Therefore it is used for induction of ovulation in infertility. Next is degarelix, right? It is a GnRH antagonist, while gostelin and leuprolide are agonist, right? They have both negative and positive effect. Why? In continuous dose they act as antagonist, while in pulsatile, if they are given in pulsatile dose, it will cause stimulation of the anterior pituitary, right? Next are oral contraceptive pills like danazole. They act at the level of ovary. Then ketoconazole, it acts by inhibiting the cytochrome 450 enzymes. Then astrozole, letrozole, exemestane, these are aromatase inhibitor that converts the prevents the peripheral conversion of androgens to estrogen. And finally tamoxifen and raloxifene, they are selective estrogen receptor modulators, right? Again, in males, the ketoconazole and spironolactone, they prevent the release of testosterone. Finasteride is a 5-alpha reductase, preventing the conversion of testosterone to dihydrotestosterone. I think this was asked this year as well. The conversion of testosterone and dihydrotestosterone, and there were 4 options relating to this only. Next, the drugs acting on androgen receptor complex or anti-androgens are flutamide, cyproterone and spironolactone, right? Now let us look at the drugs one by one. So first we'll talk about the GnRH analogues. The GnRH analogues are leuprolide, goserelin, naferelin and hysterelin, right? So what they do is that they act as GnRH agonist when they are given in a pulsatile fashion. When used in a continuous fashion, they will transiently act as GnS agonist, leading to a flare, but subsequently they will act as agonist, causing inhibition of GnRH, right? That is, what they do is that they downregulate the GnRH receptor in the pituitary, thereby decreasing the LH and the FSH, right? So what are their uses? In continuous dose, they can be used in conditions which have high estrogens. So continuous GnRH analogues are given for fibroids, endometriosis, precocious puberty. Then we already read in prostate cancer and infertility. The adverse effect of GnRH analogues is that it can cause hypogonadism, right, decrease in libido, also erectile dysfunction and the common nausea and vomiting. Next, the GnRH antagonist, the example is degarelix. The only advantage is use of GnRH analog in place of continuous the only benefit of using GnRH antagonist in place of giving continuous GnRH analogues is that there would not be any flare reaction associated with GnRH antagonist. Hence, they find use in again prostate cancer, right? And the adverse effect is due to decreased estrogen, that is hot flashes, and they are hepatotoxic. Next is estrogen. So the synthetic estrogen is ethinyl estradiol, right? This is used in the oral contraceptive pills. Then diethyl silvestrol and mestranol. So what they do is that they will bind with the estrogen receptors, and they are used in again conditions which has deficiency of estrogens like hypogonadism or ovarian failure. Then in menstrual abnormalities, right, they are given as combined oral contraceptive pills. Then they are used in hormonal replacement therapy in post-menopausal females, but remember, it is used only in case if they are used only when the symptoms of hot flashes are present, that too in moderate to severe amount. The adverse effect with estrogen is that there is increased risk of endometrial cancer. Right. Therefore, we combine estrogen with progesterone. Progesterone has a protective effect on the endometrium, right? Because we read that in continuous dose, it causes the atrophy of the endometrium, right? Other side effects or adverse effects are it causes bleeding in postmenopausal females. Then DES we already studied is associated with clear cell adenocarcinoma in the vagina of female, right? Who are exposed to it in utero. Then there is increased risk of thrombi. The contraindications of giving estrogen are in ER positive breast cancer if there is history of DVT or there is history of tobacco. This is very important, and these are also contraindications of using oral contraceptive pills. Then SERMs are selective estrogen receptor modulator, right? So the SERMs we need to study are clomiphene, tamoxifen, and raloxifene, right? And I think these are very, very important. So clomiphene is an antagonist of the estrogen receptor in the hypothalamus, and what it does that it prevents the normal feedback inhibition, leading to increased release of LH and FSH from the pituitary, which in turn stimulates the ovulation, right? Therefore, it is used to treat infertility due to anovulation, like in patients of PCOS. The side effects associated with clomiphene are again hot flashes because it is an estrogen antagonist. Then it may lead to ovarian enlargement, right? That is, it has a risk of causing OHSS. Then it can also lead to multiple pregnancies, and other side effect is visual disturbances. The next SERM is tamoxifen. Tamoxifen is antagonist. Tamoxifen acts as an antagonist at the breast, but it acts as a partial agonist at uterus and the bone, right? So the adverse effect are that it increases the risk of thrombi, especially in patients who are especially with tobacco smoking, and it also increases the risk of endometrial cancer since it is a partial agonist in the uterus. It is used to treat and prevent the recurrence of ER or PR positive cancers. That is, it is used as hormonal therapy in ER PR positive breast cancer, and it is also used to prevent gynecomastia, right? Next is raloxifene. It is an antagonist at the breast, uterus, and it is an agonist at the bones. So the side effects are hot flashes, right? Again, due to decreased estrogen. Then it also increases the risk of thromboembolic events, especially with tobacco smoking. But the added advantage is that there is no increased risk of endometrial cancer because it is antagonist at the uterus as well. Raloxifene is primarily used to treat osteoporosis. Next, we'll study the aromatase inhibitors. So the aromatase inhibitors we already know are letrozole, anastrozole, and exemestane, right? So what they will do is that they will inhibit the peripheral conversion of androgens to estrogen, right? So it is also used in ER PR positive breast cancer in postmenopausal females, right? So in ER PR positive cancer, tamoxifen is used in young patients while letrozole is used in postmenopausal females. Next, the hormone replacement therapy. It is used to relieve the menopausal symptoms, that is the hot flashes and vaginal atrophy. This question was also asked that HRT is used in all of the following except. So this is the answer, because in vaginal atrophy we give topical HRT, that is topical estrogen creams, right? Then it is also used in osteoporosis, as estrogen decreases the osteoclastic activity. Now, the most important or an adverse effect of concern is that there is unopposed estrogen, which leads to an increased risk of endometrial cancer, right? Therefore, we add progesterone when we give an HRT. Also, there is a possible risk of cardiovascular disease. Next are progestins and antiprogestins. So first, progestins, the examples are levonorgestrel, medroxyprogesterone acetate, etonogestrel, norethindrone and migestrol. Right, so what they will do is that they will bind with the progesterone receptor, they will decrease the growth and increase the vascularization of the endometrium. Also, it is responsible for the thickening of cervical mucus. Right, it is used in oral contraceptive pills. It can be used in IUDs, implants, and the depot injection, which contains medroxyprogesterone acetate, we already know. Then it can be used in endometrial cancer, as progesterone causes endometrial atrophy, in abnormal uterine bleeding. Progestins are also used in the progesterone challenge test, which is used to detect secondary amenorrhea, right? And it can also be used in chronic anovulation without estrogen. Then antiprogestins, the examples are the famous mifepristone and ulipristal. So they are competitive inhibitors of progestins at the progesterone receptors, and they are used in termination of pregnancy. Right, we know that for abortions mifepristone is combined with misoprostol, and ulipristal is used as an emergency contraceptive. Now let us talk about oral contraceptive pills. So oral contraceptive pills are a combination of progestins and ethinyl estradiol, right? And it can be in the form of a pill, patch or a ring. So what is the mechanism of action is that the estrogen and progesterone, they will inhibit the LH and FSH. This leads to prevention of estrogen peak, and estrogen peak will inhibit the LH surge. So since there is no LH surge, there would be no ovulation. Also, progestins will cause thickening of the cervical mucus and limits the entry of sperm to the uterus. Progestins also inhibit the endometrial proliferation, right, and therefore making the endometrium less suitable for implantation. The adverse effects are very important. So first is breakthrough bleeding. It can cause breast tenderness, then venous thromboembolism, hepatic adenoma, and the contraindications include more than 35 years of age for females who smoke, history of venous thromboembolism, history of cardiovascular disease, migraine, especially migraine with aura, breast cancer and liver disease. Next are the intrauterine devices. So intrauterine devices were asked this year in NEET. We are studying about the copper IUD. It produces local inflammatory reaction which is toxic to the sperm and ova. Therefore, it causes a foreign body reaction. Okay? That is important. It prevents the fertilization, implantation, and it does not contain hormone. Right? It contains metal, that is the copper. The clinical use is that it is a long-acting, reversible contraception, and it is the most effective emergency contraception as well. The adverse effects associated with copper IUD are it causes dysmenorrhea, menorrhagia, that is heavy menstrual bleed, right? And very important point to remember, which is asked, and it is a PYQ, that PID is a contraindication for the use of copper D. Also remember that molar pregnancy are also a contraindication for use of IUD, right? This question was asked this year. I think there were two questions from IUD. First was that it is contraindicated in molar pregnancy, and the second question that was asked that which of the following contraceptive can be used in a female who is lactating. Next we'll study some of the tocolytics. So tocolytics relax the uterus, right, and they include terbutaline, which is a beta-2 agonist, nifedipine, which is a calcium channel blocker, indomethacin, that is an NSAID, right? So they decrease the contraction frequency and they are used in preterm labor, and they allow the time for administration of steroids if the labor is preterm, so that it helps in promoting the fetal lung maturity, right? Then next are androgens and anti-androgens. So androgen is synthetic androgen is danazol. It is a partial agonist at the androgen receptor, and the use is endometriosis and hereditary angioedema, right? Adverse effects associated with danazol is weight gain, acne, and hirsutism. It also decreases the HDL level and it is hepatotoxic, right? Also it is associated with intracranial hypertension. Next is testosterone. It is an agonist at the androgen receptor and it is used to treat hypogonadism, also promote the development of secondary sexual characteristics, and it stimulates anabolism, helps in promoting recovery after burn or any injury. The adverse effects associated with testosterone are it causes masculinization in females, it causes decrease in the testicular testosterone in males by inhibiting the release of LH, right? That is by negative feedback, hence it may lead to gonadal atrophy. Also, it leads to premature closure of epiphysis. Then it increases the LDL and it decreases the HDL. Some examples of anti-androgens are abiraterone, finasteride, flutamide, ketoconazole, and spironolactone. Right, the mechanism, abiraterone is a 5-alpha hydroxylase inhibitor, right? It is used in prostate cancer as an anti-androgen. The adverse effects are it causes hypertension and hypokalemia. Finasteride is a 5-alpha reductase inhibitor that decreases the conversion of testosterone to dihydrotestosterone. The use is BPH and in male pattern of baldness. The side effects are gynecomastia and sexual dysfunction. Then flutamide and bicalutamide, they are non-steroidal competitive inhibitors at the androgen receptor, that is it decreases the steroid binding, and it is also used in prostate cancer. The side effects are again gynecomastia and sexual dysfunction. Ketoconazole is again a 7-alpha hydroxylase or a 1720 lyase inhibitor. It is again used in prostate cancer as an anti-androgen and the side effect is gynecomastia. And this is important. Again, spironolactone, it is an androgen receptor as well as 17-alpha hydroxylase inhibitor. It is used in PCOS, right? And the side effect is that it causes amenorrhea. Next, tamsulosin. So we've already read, we're just revising it. It is an alpha-1 antagonist, right? And it is used to treat BPH by decreasing the static component, which is it decreases the smooth muscle. It decreases the dynamic component, that is it decreases the smooth muscle tone, right? And remember, very important, it is selective for alpha 1AD receptor, which is found in the prostate, and it has no effect on alpha 1B receptor found in blood vessels. The last drug that we'll be doing is minoxidil, right? It is a direct arteriolar vasodilator and the use is androgenetic alopecia, that is a pattern baldness, and it is also used in severe refractory hypertension, right? Because it is a vasodilator, hence it finds used in hypertension. So that completes the reproductive pharmacology, and trust me on this, reproductive pharmacology is very important, as in the recent years the trend is being seen that a lot of questions are asked from reproductive pharmacology. So why it is more important is that it also covers the topic of contraception. Hope you like the video, and send your feedbacks and any correction you want to make to get featured in the video. Also remember that all queries are welcome. You can comment or leave a DM on my channel, that is Cram Chronicles. And please share this video with your friends, and do press the like button if you find this video useful, as it serves as a motivation to make more content and post more frequently. A friendly advice for all of you is to cover the first aid with me, as it will give you ample time to study your own notes and do multiple revisions before the NEET PG or INI-CET or your USMLE, whichever exam you are targeting. Also, do the PYQs from the above topics, because as I have told thousands of times that PYQ are essential to any prep. As always, subscribe if not already subscribed, and keep learning and keep aspiring. See you for the next video where we will cover the renal. Till then, take care and happy learning.